altogether different curriculum. And why I have restricted to white light endoscopy is because that is the conventional way we continue to do endoscopy. And in India, while narrowband imaging is widely available now, but still majority of the people, rather all the people, even at institutes like PGI, we continue to use white light endoscopy for most of the procedures. For selected lesions, we switch over to narrowband imaging. So endoscopy gives you endoscopic image. Basically, you have all kinds of lesions seen, ulcers, some unusual lesions like diverticulosis, some infections like Clostridium difficile. So some of these lesions are very characteristic, very peculiar. Some are not, and some you need to identify. So what is common to all these lesions is that you have to have a keen eye for detail. Now, these are small superficial ulcers. This is the ileocecal valve. So you have to cross the ileocecal valve to see the ileal ulcers. And then you have to see what kind of ulcers are these and where do they fit in the context of the patient's symptomatology or other investigations. So endoscopic reporting is in the context of the symptoms, signs, and other investigations. Some lesions, however, are very classical and characteristic, like this Clostridium difficile or pseudomembranous colitis. So when you do endoscopy, you have to describe the lesion. And that is the starting point. For a newcomer who is doing endoscopy or the second year of DNB or DM, this remains the most important part of diagnostic endoscopy. How do you describe the lesion? So starting with location. So for example, in the esophagus, you have both the options available. You describe a lesion in terms of centimeters from the incisors, or for certain lesions like the Barrett's esophagus, you describe it from so many centimeters above the gastroesophageal junction. And for that, you need to identify this columnar junction. The upper esophageal sphincter is not that clearly denoted on endoscopy, so you measure the distance from incisors. So location is the first part. Then for upper GI, for esophagus, stomach, for duodenum, for any part of the GI tract, distensibility of the lumen, the size of the lumen, and whether it is distending normally or not is also important. For certain lesions in the esophagus, you can make a tentative diagnosis of, for example, achalasia or corkscrew esophagus, just looking at the peristaltic activity or the gross view of the esophagus. So there may not be any mucosal abnormality, but you can still make a tentative diagnosis. Now, for example, in this patient, you have this whitish cheesy material in esophagus. This is the gastroesophageal junction. So this is in the lower esophagus. So this is a classical case of Candida esophagitis. In the stomach, you have to describe the lesion in the context of lesser curve or greater curvature, whether it is in the fundus or body or antrum. And here lesions are described in context of distance from the gastroesophageal junction on the lesser or greater curve, or in relation to the incisura or the pylorus. Again, you look at the distensibility. Now, for example, in this patient, the lesion which is seen here, you have this is an ulcer at the incisura, and these are vascular lesions in the antrum. You can see the pyloric opening somewhere here. So for example, in this particular case, there is a pre-pyloric lesion at the incisura, which is ulcerated 2 centimeters in diameter with a clean base with pinpoint bleeding vessels. You see these small bleeding vessels which are oozing small amount of blood. The margins of the ulcer are smooth. So this will be complete description of this ulcer, this lesion, and this will be a benign ulcer. In the duodenum, you describe the lesion in the context of whether it is in the duodenal bulb or in the second part of the duodenum. You rarely go across into the third or fourth part of the duodenum, but if you happen to go, you describe that. So in the bulb, you describe whether it is on the anterior wall, posterior wall, or at the apex of the bulb. You again, very important for duodenal bulb lesions, you describe the normal capacity or the distensibility of the duodenal bulb. So in a patient with chronic duodenal ulcer, the bulb is shortened or deformed with pseudodiverticula and is not normal looking. So you have to identify what does a normal bulb look like. Then in the second part of the duodenum, you look at the duodenal folds, the number and the height, and then the lesion if there is any. Now, for example, in this particular patient, you have in the second part of the duodenum on the medial wall a polypoidal mass. You describe the mass as a polypoidal. This is classically polypoidal with mucosal abnormality and which is friable. If you touch it with a biopsy forceps, it is friable, and the rest of the duodenum is distending normally. You measure the size by opening the biopsy forceps. You can estimate the size. So that will be complete description of this lesion. Now coming to specific lesions, what is an erosion and what is an ulcer? Something very basic and important. Now an erosion is a mucosal defect, purely mucosal, whereas an ulcer will go across the mucosa into the submucosa. So this is the mucosa, this is the submucosa. Histologically, an erosion is only in the mucosa, whereas an ulcer is at least in the submucosa. It may go deeper than that. You know that ulcers can perforate also, so ulcers can go across. A fissure, something seen very uncommonly, for example, in patients with Crohn's disease, fissure is a clean cut-like thing. In contrast to an erosion, which is irregular, ulcer is irregular. Fissure is clean cut-like, and it can be in the mucosa or in the submucosa. Now, this is an example of a pre-pyloric lesion. At incisura, there is thickening of the folds, altered vascular pattern with an erosion, and this is an ulcer. Now, how can you say that this is an erosion, this is an ulcer? Endoscopically, you can only describe this lesion, a whitish necrotic based lesion, which is elongish, stellate-like, and this one is slightly deeper than this. So there's no mucosal change around it. So this will be described as an erosion, this as an ulcer. Now some examples of erosions which can be like this or like this, and in these are all in the pre-pyloric or antral region. So erosions can also bleed. You see these bleeding spots on erosions? Then in acute gastric erosions, what is it? You can have it in stress bleed, like patients in the ICU on ventilator. So they can have bleeding because of these GAVE-like. This is just like GAVE in portal hypertensive gastropathy. Or you can have these elongish superficial erosions and patches of hyperemia. So this is stress-induced erosive gastritis. What is an aphthous ulcer? Aphthous ulcer is an ulcer which is like this with necrotic base but surrounding by a red halo or pink halo. So this is also an aphthous ulcer. This is an aphthous ulcer. So an ulcer is necrotic base surrounded by a halo. So that defines an aphthous ulcer, classically seen in Crohn's disease, but can also be seen in conditions like non-steroidal anti-inflammatory drugs and certain other conditions. Now this is an example of a gastric ulcer which I showed. So clean edges, whereas this gastric ulcer has everted edges. So when you describe an ulcer, you describe the edges. Now again, a superficial ulcer versus a deep ulcer. This is a superficial ulcer in a patient of Crohn's disease. See, it is very superficial, like just exudate being present on the mucosa. Whereas here you can make out that the mucosa is somewhere here, the ulcer is deep, and you can estimate the depth of the ulcer. So you can describe the ulcer as superficial and deep. Then you describe the ulcer in the context of the anatomy, the site. This is the gastroesophageal junction, the Z line. So there is an ulcer, elongated about 2 cm by 1 cm, clean based ulcer at the gastroesophageal junction on the esophageal or the squamous mucosa site. This ulcer is following EVL, so EVL induced ulcer. So your description must include complete details of the lesion seen. Sometimes you have uncommon lesions, ulcers, which have to be read in the context of the basic disease. A patient of hypertension, ischemic heart disease, on this was on colonoscopy. So you see the large ulcerated area with patches of hyperemia. Sometimes there is a possibility of bleed here. So this large ulcerated area, particularly according to particularly in the splenic flexure or at the sigmoid, would be classically seen in ischemic colitis. So you can have similar ischemic ulcers in the jejunum or proximal jejunum or in the context of superior mesentery artery occlusion or thrombosis. So for such kind of lesions, you need to know the basic underlying disease of the patient. Now, some vascular lesions, angiodysplasia or telangiectasia or AV malformation, these are some overlapping terms. So you will describe a vascular lesion which is frond-like, about 1 centimeter in diameter, not bleeding. This is angiodysplasia. Again, as I said, it is difficult to say that AVM, angiodysplasia, virtually overlapping terms. So how will you describe this lesion? This is in the colon, in the transverse colon. You can see the transverse fold. This is a vascular lesion, 1 centimeter in diameter, with proliferating vessels from a central point. So vessels are proliferating from a central point. The lesion is not elevated and there is no active bleed. So your description has to be complete. This was a patient of thrombocytopenia. In the esophagus, you see these punctate spots. So something like what you get on the skin, you can have bleeding in the esophagus or in the stomach, anywhere, in patients with thrombocytopenia, quite often seen in patients with dengue fever or other causes of thrombocytopenia. Now, this is an interesting lesion which must be recognized because the treatment is different, the outcome is different. These lesions can bleed repeatedly. A vascular lesion, which is a protruding vessel in the stomach along the lesser curvature, so vascular protuberance, nipple-like, there is no ulcer around it. So in contrast to a benign ulcer, there is no ulceration. All you have is surrounding mucosa is pale and the lesion is non-bleeding. So this is classically a classic dilophoid lesion, which can be there in any part of the intestine, especially in the stomach. When you inject it or you clip it, this should resolve very fast, and very characteristically, this lesion may be seen today and may heal tomorrow. So these lesions can, however, bleed profusely. Then you all know about portal hypertensive gastropathy. This is presence of this mosaic pattern of mucosa. So if it is like this without any spontaneous bleeding, it is mild. If there is spontaneous bleeding, it is severe. The severe one can have red marks or cherry red spots. So this is a severe gastropathy. This is a severe gastropathy. These are hyperemic patches in a mosaic-like mucosa with cherry red spots. So this will be classified as severe portal hypertensive gastropathy, classically described as watermelon stomach. Mallory-Weiss-Tier, what is this? This is an ulcer which is 2/3 to 3/4 below the gastroesophageal junction, and rest of it is above the gastroesophageal junction. So classically seen on retroversion. So linear ulcerated lesion with or without a bleeding vessel across the gastroesophageal junction, primarily on the gastric side. Then esophageal varices. These are obviously venous protuberances. You have to describe where do they start at the gastroesophageal junction, how long are they, what is the upper extent of the lesion, how many varices are there. Now, small, medium and large, they are classified as that. Different classifications are there. Basically, the small one, grade 1 or F1 are varices which are straight, which are non-bulbous. F2 are bulbous varices which may be tortuous. F3 are varices which touch each other. So small, medium, large, F1, F2, F3. Now in a given patient, the varices, one varix may be grade 1, another may be grade 3, and the description has to be in a semi-inflated state. If you inflate air, the varices will go apart, and even grade 3 varices, by definition, they are not touching each other. So your description has to be very complete in which part of the distension of the esophagus you are describing. Apart from the size of the varix, you have to describe whether there are stigmata of recent bleed or impending bleed. So some of them are cherry red spots. You see like spots like this, varix on varix. Then you have veil marking. So this is a veil marking, as if someone has hit the varix with a leash kind of a thing. And then you have hematocystic spot. This is the classical varix on varix lesion. So these are stigmata of impending bleed or recent past bleed. So this description of esophageal varices has to have presence or absence of any of these stigmata. Now, gastric varices are bulbous lesions, venous lesions in the stomach, classically in the fundus of the stomach. According to this classification given by Dr. Sareen, you have GEV1, that is the varix in the stomach is along the lesser curvature. GEV2 is varix along the greater curvature. These are generally in continuation of the esophageal varices. Then you have IGV1, that is isolated fundal varices, when there are no associated esophageal varices. This occurs classically in segmental portal hypertension. Then you have ectopic varices, IGV2, which may be anywhere in the rest of the bowel, in the antrum or in the duodenum or even in the colon. So this is an example of gastric varices, both GOV1 and GEV2. This is isolated gastric varices. There are no associated esophageal varices. And this is a patient of antral varix. So this will be classified as IGV2. So your description should be complete according to this classification, and you can also label them as F1, F2, F3. Some people try to do that depending upon the size, or you estimate the rough size by visual impression or measuring with a biopsy forceps at about 6 millimeter or 7 millimeter or smaller or bulbous. Now, other causes of bleeding from the upper GI tract, ulcer bleed is the second only to variceal bleed. So you can have a jet-like bleeding, arterial jet, or a continuous slow ooze, or only a visible vessel. Sometimes you may have no lesion, no active bleeding, but there may be an adherent clot. If you remove this adherent clot, you may have a visible vessel. You may have even oozing at times because of dislodgement and the disturbance disturbing the vascular lesion, or you may get a black spot, or you may get a clean base. So this adherent clot, if you remove, you can probably change the classification. So again, coming back to Forest 1A is a spurter, active arterial spurter. Forest 1B, again, this is active lesion, active ooze. So you have a visible vessel which is oozing blood, a visible vessel, two visible vessels which are oozing blood. Then Forest class 2 is when you have no ooze, no active bleeding. So visible vessel alone, like here, is Forest 2A. Adherent clot is 2B. As I said, if you remove the clot, the classification may change. And then you have a pigmented base. So the ulcer vessel, no clear vessel, but a base where the vessel would be is pigmented. So this is Forest 2C. And when you have a clean base ulcer, this is Forest 3. So description of a bleeding duodenal ulcer has to be according to Forest classification. Now, after these bit of classifications, I'll come to anatomy. coming first to the esophagus, as you make an entry into the esophagus, you have to look at the epiglottis, the false vocal cords, the true vocal cords, and whether they are opening, closing equally, or there is some evidence of palsy of one of the vocal cords, which can occur in some patients of carcinoma esophagus when recurrent laryngeal nerve is involved. So in patients with corrosive esophagitis or in patients with radiation injury, you may have adhesions of synechia. Sometimes you are unable to pass the endoscope. So what you do is you take a guide wire, pass in the center of the esophageal lumen, and over the guide wire you can pass the endoscope. Now the second extreme of the esophagus is the gastroesophageal junction. Now this is normally it should coincide with the diaphragmatic indentation. Sometimes it may, sometimes it may not. So the lower end of the esophagus has these palisading vessels. You can see very clearly here. And this is the squamocolumnar junction or the Z line. So gastric folds are seen towards the gastric side. On the esophageal mucosa side, you have these palisading vessels like these. So this is important to clearly define the gastroesophageal junction. Why? Because that is how you will describe the hiatus hernia and you will describe the Barrett's esophagus. So hiatus hernia is between the diaphragmatic pinch and the squamocolumnar junction. This is the hiatus. So again, esophageal palisading vessels and the gastric folds where they meet. If this distance is more than 2 centimeters, you call it a hiatus hernia. So this is the Z line. This is not a hiatus hernia. It is just a centimeter in depth. This is a hiatus hernia when the Z line is about 2 centimeters from the diaphragmatic crux. So this will be a hiatus hernia, and it can also be seen equally well from above as well as on retroversion. So this is the diaphragmatic impression, whereas this would be the squamocolumnar junction. So this is a hiatus hernia. Again, what is a Schatzki's ring? Schatzki's ring is a ring-like narrowing at the squamocolumnar junction in a patient of hiatus hernia. Sometimes this ring may become symptomatic. So hiatus hernia, sometimes on endoscopy, you can frankly see the gastric mucosa prolapsing. So frank hiatus hernia. Other times, you may have to estimate the depth of the hiatus hernia. Then this is an example of paraesophageal hernia. So that was a sliding hernia. And this is a paraesophageal hernia. This is the scope, and on retroversion you can see another herniated segment. Now what is Barrett's esophagus? Barrett's esophagus is when the gastric mucosa prolapse is extending onto the esophageal side, or the esophageal mucosa is replaced by gastric mucosa. This is not only the gastric mucosa, but it has to have histologically intestinal metaplasia. So this is the normal Z line, this is a wavy Z line, and this is when the gastric mucosa extends into the esophageal side in a tongue-like projection. That is when you call it Barrett's mucosa. So you have a diaphragmatic pinch, the hiatus hernia, and this is the squamocolumnar junction, and this is the extension of the gastric mucosa into the esophagus. So how do you measure it? You estimate, there are two parts of it, the circumferential extent and the maximal extent, C and M. So this is how you look at it, the diaphragmatic pinch, this is the hiatus hernia, and when you have the Barrett's mucosa, so this will be the circumferential extent and this will be the maximal extent. So from the diaphragmatic pinch to a supposed circular area, which is the bare minimum, will be the C part of it, and this will be the M part of it. So C and M. So this is, for example, C 1 centimeter and M 6 centimeters. So this is how you describe, according to Prague classification, C1, M2 Barrett's mucosa. So this again is something which should be done routinely in all patients of Barrett's esophagus. Now, reflux esophagitis is when you have erosions or ulcers in the lower end of the esophagus, which is classified as per Los Angeles classification into grade A, B, C, D. A is when the esophageal folds have erosions which are smaller than 5 millimeters. When the length of the erosion is more than 5 millimeters, it is grade B. When two adjoining folds have erosions which are coalescing with each other, it is grade C. And when the coalesced erosions occupy more than 75% of the circumference, it is grade D. So grade A is small erosions, less than 5 millimeters. Grade B is more than 5 millimeters. Grade C is when two adjoining erosions meet each other. Grade D is when the erosions are coalesced together but occupy more than 75% of the lumen. So this is LA classification of reflux esophagitis. Now, what is the classification of corrosive injury to the esophagus? You have grade 1, 2, and 3. 1 is just hyperemia. Grade 2 is ulceration. Grade 3 is necrosis. So 2A is when there is scattered ulcers. 2B is when there are confluent ulcers. 3A is when there is scattered charring. 3B is when there is confluent charring. So that was esophagus. In the stomach, scattered ulcers 2A, confluent ulcers 2B, scattered charring 3A, and confluent charring 3B. So this is how you will describe caustic injury, which is a common injury because patients with grade 3B injury are the ones who may perforate and they need to be taken care of differently. Now, as I said, in the esophagus, you look at the start with the cricopharynx. And what are the common lesions? Beyond the cricopharynx, Plummer-Vinson syndrome, that is a web which may be partial or complete. A web-like lesion associated with iron deficiency anemia and celiac disease. So, but you just don't look at it. You must dilate this, go across, because Plummer-Vinson syndrome can be associated with esophageal carcinoma in some patients. So for all endoscopies, don't stop at the first lesion. You must complete the endoscopy up to the second or third part of the duodenum because there may be additional lesions. Now, this is an example of a peptic stricture. These are examples of corrosive strictures. Now, as I said, you must not stop at the first lesion. Now, here, this patient has one stricture here, another stricture here. This patient has one stricture here, another stricture here. So, your endoscopic examination does not stop here. It must go as far as you can. So, you must dilate this and see. And for all strictures of esophagus, you must have a barium swallow beforehand. Because unless you have done a barium swallow, you will not know that beyond this stricture, there may be another stricture. So you will dilate this with a guide wire or with a balloon, and this stricture, which may be narrow, may get perforated. Now, anastomotic strictures may be eccentric or tortuous. So you see the lumen is eccentric. The lumen is here, whereas this wider seemed like a wider area, and the actual lumen was on the left side rather than the right side. Radiation esophagitis may have telangiectasia or ulceration and narrowing. Now, a very common lesion in a patient who has come with Disprin or doxycycline or tetracycline ingestion and sudden dysphagia or odynophagia is pill esophagitis. So this has to be read in the context of the history of pill ingestion. So multiple ulcers may be kissing ulcers also. Candida, I showed you a previous example. Now, eosinophilic esophagitis is not very common, but has to be noted. This is feline, like a cat. The cat's esophagus is like this. Or you may have multiple ring-like narrowings, or a combination of the two, or even mucosal islands. So, eosinophilic esophagitis, this will be telltale or classical finding of eosinophilic esophagitis, either a feline esophagus or multiple rings. Now, infective esophagitis, for example, CMV or herpes simplex, you cannot diagnose only on the description of the ulcers. You have to diagnose it on the basis of histology or cytology or other DNA probe or something like that. So in patients with immunocompromised state like renal transplant recipient, such lesions should be diligently looked for and investigated with histology. Now, not all carcinomas are proliferative or elevated. Some of the carcinomas, as you know, are superficial. So that is why this esophagus, which looked normally distending, but there is this patch of hyperemic mucosa in the mid esophagus, and you should not just let it go like that. There's a patch of hyperemia. There's no ulceration, no elevation. So this should be biopsied and described as such that geographical large erosive, a large erosion without a necrotic base with hyperemia. Now, if you had done narrowband imaging, you will see abnormal vascular pattern in this. So you must biopsy all these lesions and not just let it go that there is a patch of hyperemia somewhere in the esophagus or stomach. Now, what do you make of this when you see two lumens in the esophagus? It can be duplication cyst, it can be a diverticulum. So this is a esophageal diverticulum, another diverticulum without food residue, and those were true diverticula, and these are pseudo-diverticula. Pseudo-diverticula are small, generally associated with strictures. Now, this patient had multiple pseudo-diverticula and the lumen was here. He had non-steroidal anti-inflammatory drug-induced esophageal stricture with pseudo-diverticula. So what is the importance? That you must know the actual lumen, otherwise you may pass a guide wire here and perforate. Now, achalasia cardia is something which can be diagnosed on endoscopy with a dilated esophagus with food residue and narrowing. If you look at the peristalsis, the peristaltic waves will be very few and there will be lack of peristalsis. So you can make a diagnosis of esophageal motor disorder only by looking at the esophagus and confirm on barium or manometry. Then you have submucosal lesions which cannot be classified on endoscopy alone. You will need endoscopic ultrasound. So this was a leiomyoma, this was a granular cell tumor, which will need histology also. Now, as I said, squamous cell carcinoma may be proliferative, but sometimes there is infiltrative carcinoma. So in narrowing with ulceration should not be left as benign esophageal stricture. You must dilate it and take a biopsy. Now coming to the stomach, you know, fundus, body, antrum and pylorus. You have to describe lesions in the context of this anatomical distribution, whether they are along the lesser curvature or along the greater curvature. These are the normal gastric folds. This is on retroversion. So stomach examination is incomplete unless you retrovert the scope and see the fundus. So this is the pylorus, which has to be opened with air or with after giving Buscopan and entered to see the duodenum. Any residue in the stomach in a patient who's fasting means that there may be associated gastric outlet obstruction. As I said, no examination is complete without retroverting the scope because these lesions are often missed by forward view endoscopy. Unless you retrovert, you will not pick up these lesions. So these were two examples of a benign gastric ulcer, normal margin, a small superficial gastric ulcer. In contrast, this was a patient of gastric outlet obstruction due to a giant ulcer in the pyloric or antrum, in the antropyloric area, due to non-steroidal anti-inflammatory agent. So ulcer size is also to be noted. A giant ulcer is more than 2.5 centimeters in size. Then, as I showed you one lesion in the esophagus, which was superficial carcinoma, flat lesions, there may be flat adenomas in the stomach or anywhere in the GI tract. So verrucous-like flat lesion, which has to be biopsied. So this was a case of adenoma, which was flat. Adenomas may be polypoidal or flat. Then coming to malignancy. Malignancy may have an ulcerated lesion, a polypoidal lesion, an excavated ulcer, or in superficial carcinoma, they may be just a flat lesion. The ulcers are generally geographical with everted margins. in contrast to lymphoma, which may have multiple ulcers. And lymphoma patients will have normal distensibility, whereas patients with adenocarcinoma will have reduced distensibility. So again, you put in here and see and report on distensibility. Maltoma in patients with H. pylori positivity, very difficult to say it is maltoma unless you do histology. So histology is important for such like lesions. Now you will see a lot of submucosal lesions in the stomach. This is classical umbilicated appearance of a heterotopic pancreas, which can be seen anywhere in the stomach or duodenum. The other submucosal lesion in the stomach is the neuroendocrine tumor. The vascular pattern is normal. So you have to note that these lesions may be multiple. These have to be differentiated from, for example, in patients like multiple metastasis. Then another polypoidal lesion can be stromal tumor, gastrointestinal GI stromal tumor. This is the classical appearance that a volcano ulcer. But other stromal tumors may be without an ulcer, and this was flat or sessile, there is a peduncle. So you need an endoscopic ultrasound to define the subepithelial or submucosal lesions, and you cannot make a diagnosis only on white light endoscopy. Then coming to gastritis. This is a normal stomach appearance, some vascular pattern, glossy mucosa. This is, you see the difference here. This is a patient we had today, a young girl with dyspepsia only. So the glossiness is lost, the normal vascular pattern is lost, and there is a vague vascular pattern. And in the proximal part of the stomach, the vascular pattern was different from a normal mucosa. So you will say that the stomach mucosa is abnormal. You have to take a biopsy to see whether it is H. pylori positive or not. This is the classical normal folds in the stomach with vascular pattern, and this is what happens in atrophic gastritis, that you see some of the vessels deep below and these atrophic or thinned out mucosa. Very clearly brought out in these two patients. You see this atrophic, flat, whitish mucosa with a vascular pattern which is different from the normal. Now, atrophic gastritis in H. pylori is pan-gastritis, whereas in autoimmune gastritis, it is patchy. Again, some examples of when you see like vessels shining below and pale mucosa, this is what happens in patients with pernicious anemia. So such patients will have B12 deficiency. Rest of the mucosa in the antrum in this particular patient, again, different salt and pepper appearance. So this description should be described clearly. Don't just say that there's no erosion, no ulcer, distensibility normal. So mucosal pattern has to be described. Sometimes the folds are thickened. So this is hypertrophic gastritis. This has to be in the context of drug intake or Menetrius disease, or even patients with lymphoma can have such thickened folds only, no ulceration. So biopsy must be taken in all such patients. Then patients with post-operative stomach, you must always do a barium study before endoscoping a patient of post-operative state, whether it is esophagus or stomach, because you do not know what you are going to see, which is the afferent loop or efferent loop, which one is the loop which is blocked or ulcerated. So a barium, prior barium is a must in post-operative endoscopy. An example of gastroduodenal Crohn's, just like any other Crohn's, deep ulcers with pseudopolypi. Now coming to the last part of today's talk, duodenum. The duodenal bulb has to be described as distending normally with symmetrical walls. So this is the superior wall, inferior wall, anterior wall, posterior wall, and apex. Then you enter the second part of the duodenum and describe the folds and the distensibility. Commonest lesion in the duodenum you are looking for is ulcer, active ulcer, or if there is a healed ulcer, you may just find deformed duodenal cap with or without pseudodiverticula. There may be erosion, superficial erosion in the duodenum. Now, this is an example, normal pylorus. you enter the bulb which is not distending properly. At the apex there is narrowing and there are ulcers here and here. When you come closer to this opening, you see that there's another opening there, another narrowing there, which is after going across this. This is the second opening, and you cross this, there is a third narrowing. So this was a patient of non-steroidal anti-inflammatory drug-induced duodenal webs, multiple lesions. So don't limit your examination to first part or the first narrowing. You must go across until you see the normal mucosa. Now, don't just look at the mucosa. This was a case of roundworm in the second part of the duodenum. Giardia patients may have hyperemia, and for Giardia you can take a duodenal biopsy or duodenal fluid to look for Giardia. Now, this could be interpreted as just food residue in the duodenum. This was actually a cholecystoduodenal fistula with stones migrating into the duodenum. Then a very peculiar picture is this whitish nodules in the duodenum. You see these? This is what happens in lymphangiectasia. So this is leathery mucosa with pinpoint whitish nodules. You take a biopsy, you will diagnose as dilated lymphatic vessels in the mucosa itself. Then don't just limit yourself to description of the mucosa. This was a patient of acute pancreatitis. Now, this patient had GI bleeding some time back, upper GI bleed, no lesion found. When we went in, we found this abnormal mucosal pattern, which was just heightened villi. And there was this small opening on distension, which turned out to be pancreaticoduodenal fistula. So your examination must be, particularly in the duodenum, very thorough. And at times you may need to retrovert the scope in the duodenum. So you go into the first part of the duodenum, enter the second part, retrovert the scope and come back. This is a slightly tricky procedure, but it will give you such rare lesions in the fornices or in areas which are not easily seen on forward viewing endoscopy. Then lastly, coming to celiac disease, unless you have seen some celiac disease, you will miss it. Celiac disease can have nodularity in the first part or sparse second part of duodenal folds, or this is scalloping. This is the normal fold, but it is scalloped. You see this scalloping? This is how normal villi look, but this is how scalloping looks. And this is mosaic pattern. In between the two folds, you see this mosaic flat pavement-like pattern. So this is how celiac disease looks. So go into the duodenum, look at the folds, look at the scalloping or the mosaic pattern. Quite often we have diagnosed celiac disease in patients with portal hypertension, in other diseases, only on the basis of duodenal folds. Lastly, eosinophilic duodenitis, there's no way that you can make a diagnosis. You have to have biopsy. Duodenal Crohn's, again classical Crohn's, deep ulcers, pseudopolypi and mucosal bridging. Then polyps in the duodenum. This was a case of Brunner's gland hyperplasia in the first and second part of, classically in the first part of the duodenum. So small nodularity, more than nodularity in the first part. Then you can have just these small nodules in the folds. This also can, this was a part of polyposis syndrome, multiple duodenal adenomas, or you may have a single large polypoidal lesion, duodenal adenoma. Lymphoma, no way that you can differentiate it from carcinoma, except if the lesion is multicentric, then you make a possible diagnosis of lymphoma. Otherwise, between carcinoma and lymphoma, you have nothing much to choose in the duodenum. So to conclude, the hallmark of endoscopy, diagnostic endoscopy, is observation. Don't just pass the endoscope and look at the GE junction and the duodenal bulb. You must look at the complete mucosa in the esophagus, look at the peristaltic activity, look at mucosal pattern, vascular pattern, then only your endoscopy is complete. And in the beginning, it is a matter of time, that 10 to 15 minutes. However, as you gain experience, you can finish the examination in 5 minutes. So you must do a systemic and thorough examination. Any abnormality should be noted and described as such. So report should be descriptive. It should not be just an ulcer seen, a vascular lesion seen. You have to describe the site, these dimensions. And if you have an ulcer, for example, I told you, you must describe distensibility, peristaltic activity, associated lesions. There may be more than one lesion. So a complete examination till D2, D3 should be done. And in cases like submucosal lesions or vascular lesions or Barrett, you may need to add NBI or EUS or at times histology. So thank you very much for your patient hearing. We can have
so thank you for this wonderful atlas of upper GI endoscopy which you have shown us. Almost complete coverage of all the upper GI lesions, but that also means that we would have to have another class later on about the rest of the GI tract. Now, there are a couple of questions there. Is that how can we differentiate D2 from D3 endoscopically? I mean, when do you say it's D2 and when do you say D3? How do I? So, can you see the question from the chat box there, sir? Otherwise, tell you that
you can read it.
Hiatus. I think you have already mentioned about it, but maybe you can re-emphasize how to report hiatus hernia.
So I'll start. I can see the chat box now. So hiatus hernia is when you have a lax GE junction and the squamocolumnar junction is more than 2 centimeters above the diaphragmatic valve, diaphragmatic impression. So you estimate, identify the diaphragmatic hiatus, a diaphragmatic pinch, and you columnar junction. If the distance is more than 2 centimeters, you call it a hiatus hernia. With or without esophagitis. Duodenal fold number.
You also said that retroversion can also help us in the differential diagnosis.
Yes, retroversion will give you, show you the laxity of the diaphragmatic crux. So that is a part of the examination of the hiatus hernia. Can we differentiate D2 and D3 endoscopically? As you go down into the duodenum and the jejunum, the folds will become closer to each other. Otherwise, if you are able to identify the angle of D2 to D3, you can say that you have entered D3, but it is all empirical that you have gone this much distance beyond the papilla and you estimate that you have entered the D3. If you do a careful examination, you can even go up to the D3, D4 or D4 also at times with a conventional upper GI scope, not necessarily an enteroscope.
I think here I would also like to add to the young people that often we have this habit of only seeing the proximal D2 in the upper GI endoscopy. I think looking at the indication, always try to go as far as possible because sometimes you may miss a lesion in the distal part of second part of duodenum or third part of duodenum, and then you are looking for a bleeding lesion somewhere in the colon. Bleeding may be actually within the reach of the upper GI endoscopy. So I think this is something which you have highlighted, and which is that normally in a hurry, we just enter second part of duodenum and come out. So I think we should spend some time going as deep as possible because sometimes though rare, there may be a lesion in the distal D2 or D3, D4 which can be easily picked up by extended upper GI endoscopy. So this is major. Yes, sir.
I think going beyond papilla is important, and you must learn the trick of shortening the scope once you are in the second part of the duodenum. You shorten the scope, you go beyond the papilla, and if you don't inflate much air, you can go into the D3 at least. So that small trick is very important. What are the blind spots in upper GI endoscopy? Blind spots are just as you enter the cricopharynx, you may miss an inlet patch. You can miss a lesion there. Like a ulcer or a malignancy. Then G junction is a blind spot. You have to retrovert to see it. That is the most important blind spot. Then the fornices of the duodenal bulb are blind spots. For that, you may need to retrovert the scope into D2 and come back to visualize the fornices. This is a very rewarding exercise, and just like you make a good impression of the hemorrhoids only on retroversion in this rectum, similarly you must have retroversion at all possible sites in the upper GI tract also.
So there's questions on how do you actually measure the thickness? I mean, is it all approximation or do you actually use a scale?
Measure what?
Thickness of any fold, or when you say the thickened fold or the height, do you use a biopsy forceps to find out what is the measurements, or it's just an eye observation?
It becomes very subjective generally, but one must distend that part of the bowel, whether the esophagus or stomach or duodenum, because a lot of folds in the stomach will get effaced if you distend it well. And that is one way of differentiating, small varices from folds in the esophagus at times. So distension, and yes, if you have to measure, actually you must use a biopsy forceps, but otherwise we just give an empirical impression of thickened folds or normal. But this after distension, full distension of the part of that lumen.
There is a question of how to differentiate true polyp from a pseudo polyp.
Endoscopically, a pseudopolyp will be associated with surrounding ulceration or evidence of healed ulceration, whereas a true polyp will not be. Histologically, you can have the differences, but endoscopically, it has to be associated with underlying disease, which will be the hallmark of a pseudopolyp.
So there is a question that candida is seen in the stomach or duodenum also, or it's only in the esophagus?
Candida is generally seen only in the esophagus. Rarely ever you will see candida in the duodenum. In patients with achlorhydria, you may get candidiasis in the whole of the bowel, but in all other patients with normal acid output, you should not see candida in any part other than the esophagus.
So there is another question on duplication cyst versus true diverticulum. So can you differentiate endoscopically between a duplication cyst and a diverticulum?
No, again, endoscopically you cannot differentiate. You will just see an outpouching in the lumen. Duplication cysts generally have a very small connection with the lumen. A true diverticulum has a larger connection with the lumen. So otherwise you will need radiology.
So specific features for H. pylori gastritis. Is there any way we can say that this is H. pylori gastritis?
No, on endoscopy you cannot say. You have to have. Japanese have tried. They have given endoscopic description of magnification endoscopy of H. pylori gastritis, but not on routine white light endoscopy. Not possible.
The other question is that there are multiple ulcers. How do we know which ulcer we should biopsy?
Okay. So for malignant ulcers, when you need a histology, you have to biopsy from the edges of the ulcer. So you take generally at least four quadrant biopsy from 4 edges, and if possible from the center of the ulcer. If there are more than one ulcer, then you take biopsies from more than one ulcer. Don't limit yourself to one ulcer only. For example, in lymphoma, you may have multiple ulcers. So take biopsy from more than one ulcer, because one particular ulcer may give you necrotic base and not be representative.
I think there's a very important which has been asked, that for defining the G junction, should we use squamocolumnar junction or the proximal end of the gastric force?
Sometimes the squamocolumnar junction is very clear, and that remains the most objective evidence of the esophagogastric junction, because you have palisading vessels, you have the gastric folds, So the line between the two is the Z line. So if you can identify the Z line with the salmon mucosa of the stomach and pale gray mucosa of the esophagus, that is the easiest and most reproducible landmark, because you can tell, you can take picture, you can tell your resident that is the lesion there. So that remains the best marker. But in patients where the Z line is not clear, you just look at the gastric folds. Where do they go and where do they end? So that will be the stomach-columnar junction. Ultimately, it is the same thing.
So, clarify for the student once again, we are looking at three landmarks. One is the diaphragmatic pinch, where the esophagus is acting. Then we are looking at the gastric fold, and third, we are looking at the stomach-columnar junction. So I think for the definition of hiatus hernia, it's the first two which are important. Whereas for the diagnosis of Barrett's esophagus, it's the upper end of the gastric fold compared to the stomach-columnar junction, which is important. That gap should be more than 2 centimeters, as you mentioned.
Yes, right. Absolutely right.
Can we see Zenko on upper GI endoscopy?
Yes, of course. You have to be very careful. You see an elderly patient coming with dysphagia, no weight loss, you push in the endoscope. You have to hold your endoscope right at the cricopharynx and go very slowly. What is done in such patients is use a ERCP guide wire to pass the guide wire. You will, if the guide wire goes across into the esophagus, go there, leave the guide wire there. As you withdraw the guide wire, withdraw the endoscope over the guide wire, you can see the diverticular opening. So you must know.
The important point which sir has raised is that for evaluating the upper end of the esophagus, sometimes it's good to have a wire which makes you stable in the upper esophagus, and you can understand the anatomy there much better. So I think use of a wire endoscope helps us in the upper end of the esophagus. So sir, last three questions. Atrophic gastritis, should we biopsy?
That is a difficult question in Indian context. In the context of Far East like Japan or other countries, all atrophic gastritis are biopsied. But we don't have that much of H. pylori atrophic gastritis carcinoma sequence for different reasons, so we don't do biopsy.
What is the significance of length of esophagus, like the position of the G junction? Why do we say 36 centimeter, 38 centimeter, or 40 centimeters? So that's a question which somebody asked, that what's the importance of length of esophagus?
No, if it is really, but rarely you have congenitally short esophagus at G junction is at 34 centimeters or 32 centimeters. But otherwise, there's no significance of measuring the length of esophagus. Position of G junction, again, in the context of hiatus hernia, yes, not otherwise.
Is there any clear differentiation between nodule and polyp?
No, it is only subjective. Polyp will be sessile or pedunculated. Nodule is sessile. Small elevation is a nodule. Larger elevation is a polyp.
So I think, sir, we have crossed the time. We are already into 19.2, and we had about 130 participants in this meeting. We am sure that we would have another opportunity to go through this exercise for the rest of the intestine. We have mainly covered upper GI. We have covered it extensively. After some gap, we can have a talk from you on the colonoscopy and endoscopy if possible. Thank you very much.
Thank you.
The final comments by Dr. Kochhar, and then Navneet can close this meeting.
Right.
Thank you very much, Dr. Kochhar, for the presentation. Thank you very much, Dr. Mahesh Goenka, for joining us. Thank you, students, for joining us.
Thank you.
Okay, thank you.